it out very short. Now, what is the clinical presentation of a septic neonate? A child will come in the emergency with hyperthermia, basically, irregular hypothermia. In case of the preterm babies, where there will be a variation in the temperatures. The neurologic or the behavioral changes, that means that the baby may be lethargic, irritable, inconsolable, continuously shrill cry will be there. Poor perfusion, cyanosis, pallor, any petechial spots or rashes. To rule out any cause of sepsis, yes, decreased oral intake, vomiting, diarrhea. Cardiopulmonary, there will be tachycardia, respiratory distress, apnea and hypotension. Metabolic disorders, hypoglycemia, metabolic acidosis. And you have to see for any focal infections, whether there is any cellulitis, omphalitis, conjunctivitis, otitis media, or osteomyelitis. What investigation are we going to go? We all know complete blood count, urinalysis, CSF, blood culture, urine culture, and a CSF culture, C-reactive protein, calcium levels, electrolytes, PTA, PTTs, chest radiographs. And obviously, if you have the facility in the hospital, you can go with the D-dimer levels and your the procal levels, procalcitonin levels. Now, management, we all know A, B, C, that is airway, breathing, and circulation is the standard procedure in the initial evaluation and management of a baby. Number puncture with CSF analysis and culture, peripheral blood cultures, specific blood markers, like I told you, procal levels should be done. Now, appropriate, normally see in our NICUs, we normally used to start with AMPI or cefotaxime or AMPI or Genta. That is the best line of medications which have to start. We should not go with meropenums and piptas and all these things, because that is the second generation or the third generation antibiotics. It is not common for a neonate to have meningitis caused with methicillin-resistant Staph aureus. But normally a patient, I'll just give you an idea. A patient who comes with a staph pneumonia or staph aureus infection, they will present with a very short history of a fever and a very short history of the signs of sepsis. Like a child will present to you with just a fever of maybe 2 to 3 days, and suddenly the child is having irritability, respiratory distress. The baby may land up in seizures. And once you get an X-ray done and you find, oh, there's a pneumonatic patch, and these babies normally, which I have seen in my practice, they sometimes present to us with pneumonia leading to pneumothorax in a 3 days time only, and then you have to deal accordingly. Now, vasopressors and neurotropes in cases of septic shock, you can use it. Now, remember one thing before we go ahead with this slide. Now, the most important thing in sepsis is a blood culture. You have to understand, when we go ahead with the CBC, CRP, or blood culture, then go ahead with the CSF culture, please do not jump onto the antibiotics just like that. If you find that there is any growth in the cultures, number one, along with the clinical scenario of a baby, if you find that the baby is not improving with an AMPI-Genta or AMPI-cefotaxime, and the blood cultures are, say, sterile, then maybe you can think about changing the antibiotic to a second generation antibiotic, maybe meropenem or next stage of antibiotic. Get a blood culture done again, and then see what the growth is. So what I mean to say is, whenever you are changing the antibiotics, preferably always get a CRP and a blood culture done before we really jump onto changing the antibiotics. Right? That is the most important thing which you have to do. Now, a child who comes in a sign of shock, or the most important thing to do is basically, like I told you, airway, breathing, and circulation. If you find that the airway is okay, the stress is there, like I discussed, put the baby on oxygen by nasal bronchs, shift the baby to a high flow nasal cannula, and then second step, go with CPAP support. Second, go to the breathing part. If you find the breathing is still not settling down, go ahead and go to the ventilation procedures. Start the empirical antibiotics, send all the investigations. Then if you find that if the child is hypotensive, then the first line of the medication which you have to go with is dopamine, then come to dobutamine, and then come to noradrenaline. See, if you find that it is the cardiac involvement, the cardiac contractility is poor, then you can think about starting with non-adrenaline with a low dose of dopamine. So that has to be taken care of. Normally in our practice, we start with dopamine, then go to dopamine, and then go to noradrenaline. So that is the best way to do it. Now, endpoints of resuscitation, what I mean to say is, when we say that, yes, my child is doing fine, normal LOC, the capillary refilling is less than 3 seconds, normal pulses, warm extremities, urine output is more than 1 ml per kg per hour, decreased lactate levels, increased pH. So any questions, you please let me know. We'll just go ahead with the questions because I'm trying to be very fast. Normally, okay, now let's go to intestinal emergencies. I'll do it very fast. Now, intestinal emergency normally we find is duodenal atrasias, Hirschsprung disease, and NECs. Now, age of onset, the first days of life, duodenal atrasias, we have bilious vomitings. Get an X-ray done, you will find a double bubble sign. Abdominal distension is there. The diagnosis is made by an abdominal X-ray. Management, keep the baby NPO, put a nasogastric tube, IV hydration, and then surgical repair. In Hirschsprung disease, again, first few days of life, male predominance is more. Again, the bilious and bilious vomiting, stool is colored, maybe a jelly kind of a stool. Abdominal X-ray will find the dilatation of a proximal colon, lack of air in the rectum. Get a rectal suction biopsy done once the baby stabilizes. How to manage? Same. Put keep the baby NPO, nasogastric tube placement, IV hydration, and surgical repair. NEC, maybe in the first month of life, especially in the preterm babies, non-bilious or bilious vomiting, and the specific sign is pneumatosis, abdominal free air, portal venous gas. I'll show you the X-ray. And NPO, nasogastric tube placement, IV hydration, antibiotics, and a surgical consult to repair the NEC. I'll not go into the details, just with the clinical features. Patient with duodenal atrasia with present with first days of life with the bilious vomiting. It will reveal a scaphoid abdomen. The newborn may pass mucinum, but it is unlikely to have any bowel movements. And there will be a positive history of polyhydramnias in the mother during birth. Investigate, like I told you, there will be a double bubble sign indicating a trapped air in the stomach and proximal duodenum. So remember, duodenal atrasia, double bubble sign, D and D. Duodenal atrasia, double bubble sign. So get an electrolytes, glucose should be obtained as hydration and nutrition status. First springs will go fast. Let's go to clinical features. Most newborns, they present with a delayed passage of mucinum and a stool. They pass mucinum. Normally, newborns, they pass mucinum in 48 hours. If you find that the baby after birth has not passed mucinum for more than 6 to 7 days, think about it. Baby presenting with abdominal distension, persistent vomiting, and stingy stools. The physical examination reveals a tight anal sphincter and explosive stool with rectal examination. Extreme, like I told you, this will be distension will be there, pain and perforation. The child will land up and come in shock in the emergencies. Investigation, rectal section biopsies, like I told you, anal myometry and barium enema will assist in the diagnosis. NECs, I'll go fast, mostly preemies, like I told you, advancing enteral feeds. When the baby is on the enteral feeds, they land up into NECs. And now, how to diagnose feeding intolerance, abdominal distension, hematochezia is there. The baby will suddenly go into signs of sepsis. Normally, NEC and sepsis, they mimic each other very well. So, lethargy, apnea, DAC, shock, and cardiovascular collapse will be there. So, you have to be very precautious about these things. Now, the lab diagnosis is very important along with the X-ray findings. Remember one thing, abnormal WBC, thrombocytopenia, hyponatremia, elevated PT and APTT levels, and metabolic acidosis. Remember in NEC, abnormal WBC, thrombocytopenia, hyponatremia, elevated PT, APTT, and metabolic acidosis. Radiological, I will just show you the X-ray. Like I told you, there will be dilated bowel loops, thickened bowel loops, and the findings are of pneumatosis intestinalis. Let's just see if I can get the X-ray for you. Just a sec. Now you can see this X-ray very categorically. You can see there's a if you can see it just looks like a train truck lucency. See the air bronchograms. You can see the air bubbles which are seen. So this is basically because of externalization of the air from the lumen. You can very clearly go through it. Hematological emergencies, bruising, bleeding, petechiae are most common seen. Now, hematological emergencies, now there are last two emergencies which are going to go. Hematological emergencies, which I'm mostly going to take care, is the bleeding neonate. A baby who's a bleeding neonate comes to the emergencies, what has to be done? Bruising, bleeding, and petechiae are most common. Now, presenting issues in the newborns, it should raise a concern and broad differentials should be maintained for these clinical features. Now, in a neonate, alloimmune thrombocytopenia, maternal antibodies cause the placenta and they target parenterally. I'm not going to into the pathology details. Now, what are the clinical features? Let's see this. Patients may present with easy bleeding, petechiae and purpura. SS in males who are basically experiencing prolonged bleeding in cases of circumcision. Mental status changes should be there, like intracranial hemorrhage. The baby may be consider vitamin K deficiencies, neonatal alloimmune thrombocytopenia, autoimmune thrombocytopenias, non-accidental traumas, infections, underlying coagulopathies, DICs, as in cases of NECs, leukemias, and HLH. Now, what are investigations? This is more important. The investigation is blood count and the coagulation profile. Go with the infectious workup. Go with the cranial ultrasounds, the first and the foremost thing. And then maybe go into the CT scan to know any intracranial bleeds. And hematological and oncology consult should be taken. Now, you have to understand this. If the platelet, now this is a very important slide I have taken out. Now, if the platelet levels are normal, the platelet function disorder with bleeding, if the platelet count is less than 100, and if there is a major bleeding, DIC should be separated, preoperative, and sepsis should be separated. If the platelet count is less than 50,000, minor bleeding is there, extreme transfusion, and in preterm infants, in sepsis. If the platelet count is less than 30, asymptomatic term infant. Now, what to treat and how to treat? Consider fresh frozen plasma in cases of moderate to severe bleeding, in cases of DIC. If concerned for an antibody-mediated process, then think about giving IVIG and appropriate transfusion. Now, IVIG can be given as 1 gram per kg per day over a period of 48 hours. Steroid infusion should be considered as an adjuvant therapy. Antibiotic therapy should be given in cases the baby is having any kind of infection or sepsis. Toxins, let's just see maternal toxins, and I'm just not go into this. Now, the last which I'm